All right, welcome everyone. In this masterclass, we are diving deep into Chylomicronemia Syndrome. We're going to really focus on the absolute heart of the therapy, which is nutritional management, and see how it fits together with some of the incredible new pharmacology that's just coming out. Okay, let's jump right into a situation we've all seen. You get that critical lab value back. Triglycerides are over 1,000, maybe even 2,000 or 3,000. The plasma looks like milk. You're worried about pancreatitis, of course, but what's the fundamental breakdown here? What system has failed? And more importantly, what's the most powerful thing we can do about it? That's what we're here to figure out. So the magic number, the line in the sand we're talking about, is a triglyceride level over 880 milligrams per deciliter. Now, this isn't just your garden variety high triglycerides. This is the very definition of chylomicronemia. It means the blood is literally saturated with these particles, chylomicrons, that are supposed to carry fat from your food. And here's the most important concept to grasp right away. This is not a problem of the body making too much fat. It's a problem of clearance. The system that's designed to pull dietary fat out of your bloodstream is either broken or just completely overwhelmed. So let's take a quick look at how that's supposed to work.
You know, in a healthy person, it's a really elegant three-step dance. Step 1, you eat some fat, your gut packages up into these little transport vehicles called chylomicrons. Step 2, an enzyme, lipoprotein lipase or LPL, acts like a bouncer at the door of your blood vessels, breaking those chylomicrons down. And step 3, the good stuff gets taken up by your tissues for energy. Clean, simple, and super efficient.
In chylomicronemia, the entire story really just comes down to this one simple fact. Step 2 fails. That LPL bouncer is either missing in action, totally asleep on the job, or there's such a massive crowd trying to get in that it's just completely swamped. And the result? You get this huge toxic traffic jam of chylomicrons backing up in the bloodstream.
Now, figuring out why that LPL system is broken is probably the most critical diagnostic step you can take. Seriously, it determines every single thing you're going to do next. We have to figure out which of two buckets our patient falls into: familial chylomicronemia or multifactorial chylomicronemia.
Okay, so think of it this way. On the left, FCS is a hardware problem. It's a rare genetic defect where the LPL machinery is basically missing a critical part. It's just non-functional. But on the right, MCS is more of a software and traffic problem. These folks have some genetic susceptibility, sure, but it takes this perfect storm of other things, like uncontrolled diabetes, alcohol, certain meds, to completely overwhelm their system, which is only partially broken. This difference is everything. So because the whole problem is an inability to clear fat from the diet, our number one go-to therapy isn't a medication, it's the food. And I really want to stress this point. This is not a lifestyle choice. This is a hardcore, mechanism-based medical treatment. It's just as vital as insulin is for someone with type 1 diabetes.
And here's the number. This is the prescription. Less than 20 grams of total fat per day. To give you some context, 1 single tablespoon of olive oil has about 14 grams. A small handful of almonds, that's 15 grams right there. We're talking about a diet that is radically, almost completely fat-free. The entire goal is to just stop making chylomicrons to begin with.
So what does that actually look like for a patient? Well, it means they have to become a fat detective. All the obvious fats, oils, butter, margarine, they're gone. But the real work is hunting down all the hidden fats in processed foods, fatty meats, nuts, avocados, you name it. Cooking suddenly becomes all about steaming, poaching, boiling. And alcohol, absolutely forbidden, since it just cranks up triglyceride production.
Okay, so you're probably thinking, if you take out almost all the fat from someone's diet, how do they get enough calories to live? How do they avoid feeling hungry all the time? Well, this is where we get to be clever. We use a nutritional workaround, a hack really, that lets us sneak calories in by completely bypassing that broken pathway.
And that workaround is MCT oil. See, unlike the normal long-chain fats in our food, these medium-chain fats are special. They have a secret VIP entrance. They get absorbed right from the gut into the portal vein and go straight to the liver. And here's the beautiful part. They don't need to be packaged into chylomicrons at all. They completely sidestep that broken LPL system, giving us a safe way to deliver fat calories.
And please, this is a non-negotiable counseling point you have to make. Patients will hear MCT and they'll immediately think coconut oil. You have to explain to them that coconut oil is loaded with other types of fat that act just like long-chain fats. Using it will absolutely form chylomicrons and completely undermine the whole diet. It has to be pure prescribed MCT oil, no exceptions.
So once that super strict dietary foundation is in place, we can talk about adding medications. And our entire strategy here comes back to that first big question: FCS or MCS? Are we trying to prop up a weak system that's just overwhelmed, or are we trying to find a whole new way around a system that's completely broken? Take a look at this. For our MCS patients, the ones with the overwhelmed system, our standard triglyceride drugs like fibrates and high-dose omega-3s, they actually work pretty well. They give that weak LPL system a much-needed boost. But look at that little note at the bottom. In FCS, where there's no functional LPL to boost in the first place, these drugs are totally useless. This is exactly why that initial diagnosis is so important. For FCS patients, for decades, the story was diet and that's it. But that has been completely upended by a new class of drugs. These are so cool because they don't even try to fix LPL. Instead, they go after a different protein called ApoC3, which basically acts like a brake on clearing triglycerides. So by inhibiting the brake, we open up all these other LPL-independent ways to clear the fat.
And here's the new toolkit. We've got drugs like Lazarsan and Plozasiran. They all target that ApoC3 brake pedal. And just look at these efficacy numbers. We are talking about triglyceride reductions of 50, even up to 80%. For an FCS patient who has spent their entire life with triglycerides in the thousands, this is, well, it's an absolute game changer.
And this timeline just shows you how fast the space is moving. I mean, we're talking about approvals happening basically right now. This is not yesterday's medicine. For decades, the only thing we could offer these FCS patients was this incredibly punishing diet. Now, thanks to these targeted therapies, we're in a completely new era of management.
Okay, so we've talked about the long-term management plan, but what happens in a crisis? What do you do when one of these patients shows up in the ER with acute pancreatitis? Your actions have to be fast, aggressive, and precise.
Here's the playbook. Step 1 is the no-brainer. Make them NPO to stop any more chylomicrons from being made and pour in the IV fluids. Step 2 is the secret weapon. Start an IV insulin infusion. And yes, you do this even if the patient isn't diabetic. Insulin is a potent activator of LPL. Then step 3, if things are really bad and the TGs are sky high, you have to consider apheresis to physically filter the chylomicrons right out of their blood. So let's just wrap it all up. If you take nothing else away from this, remember these 4 points. Number 1, first and foremost, you have to distinguish FCS from MCS. Everything else flows from that. Number 2, the diet is the absolute cornerstone, that radical, less than 20 grams a day plan. Free. Use that nutritional hack, MCT oil, to safely provide calories. And finally, number 4, for your FCS patients, these new ApoC3 inhibitors are a revolution. And that really leads us to our last thought. We can understand the pathways and memorize the drugs, but at the end of the day, this is an incredibly demanding, lifelong disease. This diet impacts every single part of a person's life, every holiday, every meal with family, every social event. So the real question for us as clinicians is, how do we go beyond the science and support the whole person as they navigate this immense daily challenge?